and a consulting psychotherapist. You were first a psychiatric nurse and with a 45-year experience in mental health. And you've been working from 1998 to 2018 as a head of a nursing discipline at the Tavistock and Portman NHS Trust. Is that so? And you served as a lead clinician for adult and adolescent services, and you also was working in a unit for treatment of patients with severe mental health disorders and personality disorders. And so you have resigned from your position as a governor at the Tavistock in 2019 due to concerns about the management of the gender identity service. And your wife, Susan, was the first clinical whistleblower on these issues in 2005. And you followed, I mean, with her, and you wrote 4 books. And if I got it well, your 4th book is going to be published by Karnak tomorrow. Is that right?
Oh, fourth.
Fourth, is that the 4th one? All right.
Yeah.
And so it's your 4th book is about the title is Identity and the Foundational Myth: Psychoanalytic Insights into Gender Dysphoria. And so the idea is that you're going tonight to talk about your experience at the Tavistock Clinic, what happened, the alarming stories that you've seen there, and also you will tell us and explain us how the politics got into the Tavistocks, and how people got so much into the ideology and how they conformed and they got submitted, and there was a restriction in the freedom of thinking. Je traduis et puis Patrick, je vous introduis. Donc Marcus est infirmier psychiatrique et a travaillé pendant 45 ans en hôpital psychiatrique. Il est membre titulaire donc de l'Institut de psychanalyse et il est psychothérapeute consultant. Il a travaillé en tout cas comme infirmier psychiatrique à la Tavistock et Portman NHS Trust de 1998, je le dis à la française ce soir, jusque 2018. Et il a démissionné de son poste en fait de gouverneur de la Tavistock en 2019 en raison de toutes ses préoccupations par rapport à ce qu'il se passait dans le Gender Identity Service. Son épouse, en tout cas Suzanne Evans, a été une des premières lanceuses d'alerte en 2005 sur ces questions. Et l'objectif, en tout cas ce soir, c'est que Marcus nous parle de son expérience à la Tavistock, de la pratique clinique, en tout cas dans le service des troubles de l'identité de genre, ce qu'il s'était passé, des histoires alarmantes qui s'y sont passées, et principalement aussi de comment est-ce que les politiques se sont infiltrés au niveau de la Tavistock. Comment est-ce que les gens, en fait, ont de plus en plus été intimidés, se sont conformés, ont été soumis, avec finalement une restriction dans la liberté de penser. And Patrick, you're a psychiatrist, you were training psychoanalyst, and you were co-founder of the Psychoanalytic Society for Research and Training in Paris. You've been working, and following the work of the observatory from the beginning, and you've written 2 books. The first one is The Psychoanalyst During Session, published in 2001, and then the second one, Driving Soma, a transformational process in the analytic encounter, published by Karnak in 2014. Et donc voilà, pour ceux qui ne le connaissent pas, Patrick est psychiatre, psychanalyste, formateur, cofondateur de la SPRF, c'est juste Patrick?
Société psychanalytique de recherche et de formation.
Voilà, et vous avez publié 2 livres, Le psychanalyste pendant la séance au PUF en 2001 et le deuxième, Driving Soma, A Transformational Process in the Analytic Encounter chez Carnac en 2014.
Merci Beryl. Donc on va donner la parole à Marcus Evans pour une demi-heure, 5 minutes. Il va y avoir des interruptions pour que Beryl puisse faire des points en français, comme ça, ça vous permet, ceux qui n'arrivent pas à mettre la traduction, transcription, d'avoir des sortes de synthèses en français, mais ça sera pas une traduction simultanée ni consécutive, ça sera juste des points en français. Ok, Marcus, you can speak now.
Okay, thank you. Thanks
Thank
very
you.
much for having me. And do tell me, when I've got to pause or slow down or whatever. Just tell me what to do. We all need supervision. I especially need supervision. So I'm not an activist. I'm a clinician, and my main interest before getting into this area, in fact, my first 2 books are about the application of psychoanalytic ideas in psychiatry. That's been my passion for most of my professional life. But to go back to how I got involved in this is the biggest scandal that I've come across in my 45 years in psychiatric practice. So I used to run a parasuicide service at King's in the 1980s. And one of the things I was conscious of was what was peddled around at the idea at that time was the very small number. And forgive me for those of you who know all this. I hope I'm not teaching grandmothers to suck eggs, but there were small numbers of mainly adult, male to female patients, say 80%, very small numbers every year. But what was said at the time was all but 1% make a successful transition. Well, I was in charge of parasuicides at King's College Hospital, and I got a regular throughput of patients who had sexual reassignment surgery and then regretted the surgery on the basis they believed it would cure them of their difficulties. They have the surgery and then they came out the other side and they still had the same difficulties, but they'd had the body modifications and they would parasuicide. And I knew it was more than 1%. But this is one of the problems in this area. There's been as well as the ideological infiltration into the clinical area, there's a lot of bogus science which gets sort of spoken about, but which has very little evidence behind it. And that was something that Hilary Cass said in her very thorough 4-year report. There is very little quality evidence in this area. And she said, we're conducting a live experiment, but we really don't know what we're doing. So she put a lid on things. So to go back again into sort of a little bit of the history, it's quite interesting the way that the clinical environment got captured by this political ideology. So moving on, I talked about the 1980s. So moving on to the early 2000s, there was a small service, a national service for under 18s run at the Tavistock. The Tavistock is the health service, special hospital for psychotherapy training. Anyway, so we had this small unit seeing about 100 kids a year. And my wife, as she's a general nurse and a psychotherapist, she went to work on the unit. And what she told me was that she was alarmed. The Tavistock has a sort of very open, multidisciplinary culture. It's quite democratic, and we're interested in people's ideas. And what she would say is she was concerned that, let's say a kid with autism, 15 or 16, was seen 4 times by the clinicians, and then she'd be presented what was going to happen, and the child was being sent to the endocrine unit. My wife, who's not afraid to speak her mind, would say, but this kid's got all sorts of comorbid problems, family problems. This seems very rushed. What are we doing? And she was made to feel that her thoughts and questions were unwelcome. I said to her, she seemed to be lacking confidence. She should go back in and question things and one thing and another. I couldn't believe what I was hearing within this sort of silo within the Tavistock. It seemed very unusual to me. Anyway, it made her unwell, really, after 6 months of trying to go against the culture. She found herself rather isolated. So I said to her, well, we talked about it, and I said, well, you better go and see the medical director because no one's listening to you. And David Taylor, who was an analyst and the medical director, he did a very thorough review. He brought in a senior psychiatrist from outside the trust called Jim McKeith, and they interviewed people. And he came to the conclusion there was not enough questioning of the treatment modality. There was no outcome measures. There was no intended research. And given this is a national service, that seemed very strange. And he basically thought that it was very poorly led clinical service. And there needed to be much more caution, much more thought, and much more challenge to what was going on. Now, those reports would be seen by the management in the trust, of which I was a member in 2006. And that report was never discussed with the senior managers. It was very odd. It was buried. And I was interested because Sue was the whistleblower who'd provoked the investigation. Okay, so she left the service. The service got bigger and bigger and bigger as this sort of contagion developed and gathered pace, till by the time it was closed down, there were thousands of children presenting with gender dysphoria at a younger and younger age. The demographic had changed from the 80% male to female over 18. We're now dealing with 80% female to male at puberty, and a quite different demographic from the old patients that I'd seen in the course of my psychiatric experience. Now then, a colleague of mine, a guy called David Bell, he's probably the best known. He was an ex-president of the British Psychoanalytic Society. He was a governor at the time, and he was approached by 10 members of the now very large clinical service. And they were saying similar things to what Sue had said in 2006. We're now in 2018. So in 2018, you've got 10 people coming saying, these kids have got comorbid problems. There are problems in the family. We're not taking enough time to properly evaluate what is going on. And they're being rushed through because of the fixed nature of their thinking and because of the fact that the service now affirms people. So if they come with a belief they're trans, it's not just a matter of empathizing with them. You're supposed to endorse that position. Yes, you're trans and we want to support you. So the culture had got much more fixed in that the patient's view must be not just empathized with and understood, but agreed with. So many more children were being fast-tracked through to the either puberty blockers by then or cross-sex hormones. At the same time, 10 parents had also written into the trust board to say they were very disappointed with the Tavistock's approach. And basically what they said in their letter is what Sue and I have been contacted over the last 6 years since we took a stand. And if I could just caricature the letter, John has been neurodiverse, for a long time. He struggles to relate to other kids. He's an outlier. He went along to see a school counsellor who heard his symptoms and said, "You're trans." He then spent 6 months online being encouraged by online groups, and now he's got a fixed belief that he's got a transition. And if we don't go along with him, he's absolutely certain, and if we don't go along with him, then he either calls us transphobic or he threatens to leave or commit suicide. And the parents are broken. They've lost their authority. They're fearful they don't trust the services, and they're fearful about their relationship with their son or daughter. And if I've heard this message once, I've heard it hundreds of times. Okay, so we go back to Dave Bell in 2018. He then has stepped down as a governor, but in the meantime, he told the trust board that he was doing a report. He does his report, they know about it, but then they see the report and they are absolutely horrified. They then start a campaign of trying to shoot the messenger, as we say, undermine Dr. Bell's credentials. He's done this as a rogue individual. This wasn't sanctioned by anyone. All lies, complete lies. Now, then I took his place as a governor. I'd retired from the trust by then, and I took his place as a governor. The first thing that lands on the desk is Dr. Bell. No, they didn't allow me to see Dr. Bell's report. They didn't want to show me the report. But what they were going to do was a medical report with the new clinical director, and that we would discuss his report. Dr. Bell's report was not going to be allowed. I then had an argument basically with the trust about the fact that I was a big boy. My job is to oversee the functioning of the trust, and I want to see all the reports, not the ones they want me to see. I want to see the lot. And that followed a 6-month argument between myself and the trust board. Anyway, the trust board were trying to use the new medical director's report to bury Dr. Bell's concerns. And this is exactly what happened to the original report, if you remembered, by Dr. David Taylor, which had raised similar concerns, which had never been publicised. So I resigned and was immediately contacted by journalists who were interested in what was going wrong in the Tavistock. We had a meeting at the House of Lords in which, that's our sort of governance establishment, in which there were people from America. There was like 5 of us on the panel: endocrinologist, a parents group, a woman who looked at what was going on in schools with sex education, and myself. Dr. Bell was not, he was threatened with disciplinary action if he spoke about this issue outside the trust. So he attended, but he wasn't allowed to be on the panel. Anyway, what you learn is that you put piecing things together. As I think Céline had said, this whole area, no one's allowed to talk about it. No one's allowed to discuss it. But you began to get a picture that this is a very sizable problem when you see it's a problem in America and it's a problem in schools and one thing and another. Now, the thing is that all I was advocating for was as an open discussion about what was going on with these kids and what, why this treatment pathway, like any other pathway, can't be thought about, challenged, researched, There's no research come out of the Tavistock apart from one study over 20 years. Now, so one of the phenomena that you come across in this whole area when you're seeing the kids, when you're dealing with the clinics, when you're dealing with the political area, is the moment you start to try and think in an open way about this, you get accused of, I see someone's called me transphobic, you get accused of being transphobic, and the accusation is you're trying to shut them down, where in actual fact it's a projection, because they want to shut you down and shut down any freedom of thought or dissent. There can be no contention in this area. You just have to agree with really what is like a religious fundamentalist view. My point is, I'll come on to, is it's very much connected with the sort of restriction of thought that you see in the patients, where they surround themselves with a certainty about who they are and what they need, and that any questioning of that certainty is felt to be antagonistic and unhelpful. And that's the pattern at a social level, clinical level, and individual level in my experience. But as I say, I think it's part of the clinical picture. So the various different medical bodies hadn't been questioning what was going on. The trust had been allowed to give puberty blockers at a younger and younger age. No feedback to NHS England, who oversee the contract. It's just like a wave gate that goes through. Yes, we need kids of 14, 12, 11 to get puberty blockers. The trust had, the service had a very unusual relationship with the trans affirming charities. Very unusual. I used to run the adult department. We had relationships with charities, but we're not hand in a glove. We're an independent clinical service. The mermaids and Stonewall were virtually writing the policies and procedures of the service. So it was a very unusual and I think very unhelpful relationship, again, which Hilary Cass brings up in her report. So what do you do when you can't rely on the medical authorities to thoroughly oversee what a clinical pathway is up to?
Marcus,
Yeah.
yes, oui, Beryl, peut-être. Alors, je voulais juste dire que, attendez, je regarde, j'ai dû sortir quelqu'un, donc qui, vous avez vu, hein, j'ai donc une transactiviste. I put her off. Je sais pas comment on dit. Yes, there was a transactivist. So it's okay now. But
Okay.
yes,
Yeah.
yes. Heureusement qu'on
Okay.
peut contrôler avec. Sauf que j'ai rien entendu
Yeah.
parce qu'il fallait que je vois comment la mettre. Bon, s'il y en a quelqu'un d'autre là, vous voulez bien sortir parce que c'est un peu pénible. Je crois qu'il y a plus de transactivistes là maintenant. Beryl, tu fais un point?
Oui, tout à fait.
Ouais.
Marcus explique effectivement qu'il n'est pas activiste, qu'il est effectivement clinicien. Vous avez d'abord parlé, Marcus, de votre expérience avec un petit nombre, en tout cas, de male to female adultes, où effectivement vous observiez, en tout cas, qu'il y avait des regrets, en tout cas, autour des questions de transition. Et certains d'entre eux qui étaient suicidaires avec finalement la pensée qu'au travers de la transition, ça allait pouvoir aller mieux par la suite. Et puis en fait ils prenaient conscience dans le décours que ce n'était pas le cas. Et vous disiez effectivement donc qu'à l'époque, là on était dans les années 90, on disait que c'était moins de 1% des adultes, mais que votre expérience clinique en tout cas montrait qu'on était dans des chiffres au-delà de ça. Et que ce qui effectivement ressort, c'est la faible qualité des preuves, en tout cas dans ce domaine, et la capture assez rapide de ces questions par l'idéologie. Alors au départ, vous indiquiez que à la Tavistock, il y avait une toute petite unité qui recevait des mineurs, qui avait une centaine en tout cas de jeunes qui présentaient des questionnements voilà, de genre qui se présentaient en tout cas par année. Et que la culture de la Tavistock était vraiment une culture très multidisciplinaire, avec voilà, une grande ouverture, et que lorsque l'épouse donc, de Marcus travaillait voilà, à la Tavistock, elle a rapporté à Marcus, en tout cas, que voilà, il y avait des enfants avec de l'autisme qui étaient vus 4 5 fois par l'équipe et puis qui finalement étaient renvoyés très rapidement chez l'endocrino, alors que ces enfants avaient beaucoup voilà, présentaient des comorbidités. Et au départ, Marcus voilà, se disait, mais moi, voilà, je peux pas comprendre qu'elle se sentait un petit peu mise voilà, sous silence quelque part. Et donc, il a suggéré à sa femme, qui se sentait isolée, en tout cas dans ce qu'elle percevait, de pouvoir en parler au directeur à l'époque voilà, de la Tavistock, qui a décidé de faire venir à l'époque, donc on était dans les années peu avant 2005, l'équivalent d'un audit externe qui était un psychiatre dont je n'ai pas retenu le nom. Je ne sais pas si Patrick, vous avez retenu le nom du psychiatre cité.
Non.
David Bell,
Non.
David Bell.
Euh,
non?
c'était préalablement, en tout cas, qui était un premier audit externe qui venait de l'extérieur, en tout cas,
Ah,
qui a été également pointé à ce moment-là que on était avant la période en fait où David Bell a été sollicité par les personnes internes, en tout cas aux guides. Et à ce moment-là, effectivement, le rapport qui n'a jamais été publié
hmm,
de ce psychiatre, en tout cas externe, était que on ne questionnait pas assez, en tout cas, qu'il y avait trop peu de transparence. Mais voilà, ce rapport est tombé dans les oubliettes. Et c'est seulement par la suite, en tout cas, que Marcus a rapporté, donc on est presque 20 ans, pardon, 10 ans après.
Taylor, Nathalie dit Taylor, hein.
Ah,
C'est
c'est possible,
Taylor?
ok,
Ouais.
oui. Donc en 2000, qu'en 2019, à ce moment-là, voilà, que de nombreuses personnes, en tout cas une dizaine de personnes, est allée voir voilà, David Bell à ce moment-là, qui lui était directeur, en disant effectivement qu'ils étaient inquiets, qu'il n'y avait pas assez de temps pour évaluer les patients, que finalement il fallait adhérer à la nature, quelque part, on pourrait dire fixe de leur pensée, qui était en fait que ben voilà, c'était comme ça, c'était leur identité était comme ça, et que c'était même plus une question d'être en fait empathique, c'était une question qu'il fallait être d'accord en fait avec eux,
Mhm,
et que de plus en plus rapidement, de plus en plus d'enfants se sont vus prescrire des bloqueurs de puberté et de plus en plus tôt. Et donc, dans le décours, en fait, Marcus expliquait que divers parents, des parents, en fait, se sont regroupés pour envoyer des lettres
mhm,
en disant, mais moi, en fait, mon enfant avait voilà, tel et tel symptôme, et puis il a été voir un conseiller à l'école, en fait, qui lui a dit, tu es trans, et que cet enfant, en fait, a passé voilà, 6 mois sur les réseaux sociaux, et puis s'est adressé à la clinique, à la Tavistock, et puis a été pris, en fait, dans le mouvement, et que ça, c'était une expérience qui était partagée, en tout cas, par voilà, de plusieurs parents qui témoignaient d'une forme de sidération, en fait, dans la prise en charge voilà, de leur enfant. Et donc, c'est comme ça, effectivement, que, et là, il me manque une étape dans la compréhension. Si j'ai bien compris, la Chambre des Lords a été interpellée, mais que David Bell a dû rester en dehors, en tout cas, du panel qui avait été auditionné à la Chambre des Lords. Et donc, que finalement, ce qui en ressort, c'est que au plus on essaye de penser, au plus, en fait, on doit adhérer en fait fondamentalement à l'idée et que les patients finalement développent une certaine forme de certitude et que toute forme voilà, toute forme de questionnement en fait est devenue tout à fait antagoniste à la logique de mise à l'œuvre en fait de la prise en charge à la Tavistock. Et donc, pour terminer, ce que Marcus évoque ici, c'est qu'effectivement, là où, par exemple, les services adultes avaient l'habitude de collaborer avec des groupes de patients ou des groupes plus activistes adultes, jamais dans le domaine de la prise en charge des adultes, ce sont les groupes activistes qui ont pris les commandes, en fait. Ils étaient, voilà, partie prenante dans les discussions, dans les échanges, la compréhension, mais qu'ici, chez les mineurs, quelque part, Marcus décrit que certains groupes activistes ont décrit les guidelines quasi de prise en charge, comme Mermaids ou d'autres dont j'ai oublié effectivement le nom, et que ça, c'était relativement de l'inédit dans cette clinique de prise en charge au niveau pédiatrique, en tout cas des mineurs avec troubles de l'identité de genre.
Merci. OK. You can go on.
Yeah, carry on. Okay, so what do you do when medical authorities no longer sort of overseeing the governance? So Sue decided to take a judicial review. That's something that you go to the High Court to challenge the government. And so she got experts from all over the world, actually, endocrinologists. Or it's very difficult to get people to speak up. We couldn't get any endocrinologist in England to speak. We had to get someone from America. We got the top professor in autism and various other things. And then presented, this was the first time that the trust was required to present their thinking and their work to 3 High Court judges. I'm not going to go into great detail, but there were a couple of jaw-dropping moments. At one point, one of the judges said, I've looked through the papers and I can only find one study. Are you saying that a whole of our country's approach in this area is based on one study? It's called the Dutch Protocol, done in Holland on 70 boys, 20 of whom dropped out in, I can't remember the date, 2000, 10 years ago, 15 years ago. And the answer was yes. That is the bridge on which all the medicalization of kids in Great Britain is based on. One study. The second question is, but where's your research? Where's your research? What have you been doing? Of course, they hadn't been following the kids up. So you've got vulnerable kids on an experimental treatment. I mean, even the medications are off license. They're not licensed for this treatment and they're not being followed up. So we've got no idea what these thousands of kids, what happens to them. The second question was, and what percentage, because we had this world-class professor of autism, what percentage of these kids are autistic? The clinic hadn't been collecting information about the comorbid factors because they weren't functioning as a clinic that looked at the kid as a whole. They were looking upon it as if the eating disorders or the autism could be divided from the presentation of gender dysphoria, as if a person is divisible into various different parts. So this was alarming. Anyway, the other thing was the case, the face of the case was taken over by Keira Bell. Keira Bell was seen 4 times as a youngster, extremely disturbed background, cross-sex hormones. She can't have kids. She's infertile, double mastectomy, got to 23, 22, and thought the whole thing was a mistake. So she was obviously the face, because the lack of care and serious thought is an absolute disgrace. Unusually, they won the case, because you don't usually beat the government. But I think the judgment was that a child who is put on a medical pathway as a minor, which, and this is the thing that was said, Domenico Gicelli, who set it up, he called it a pause for thought for kids who weren't ready for puberty and the development of secondary sexual characteristics. In actual fact, what happened was 90% of the kids, once they started puberty blockers, they go on to cross-sex hormones. There's no pause. They just go on the conveyor belt. So the judges were said, you cannot ask a 12-year-old, 14-year-old, 15-year-old to consent to a treatment pathway which may lead to them being sterile when they're not informed enough as to be able to make a decision. Now, the obvious thing to me, and this is what I said many times, is, of course, we know that this is an identity development disorder, and that in puberty, you've got the physiological, psychological, and sociological changes that create turbulence in the adolescence. And it should play its way out without interfering with the sort of ordinary pathway. It's distressing, particularly for kids who are not ready for the adult world. They may not be ready for their sexuality, but you can hold your nerve. And the serious piece of research by Ken Zucker, which is Canadian psychologist who worked in this area for many years, was that if the kids are not interfered with and supported, 85% of them, their symptoms desist by the time they get to 18, 19. So, but if you interfere medically at an early age, you set them off on a different pathway, because I believe they feel they can control the demands of the hormonal developments that take place during puberty, with all of the attendant anxieties and questions. Who are you going to have sex with? Who's going to love you? What are you going to do when you leave home? All of these that are part of the transition from childhood to adulthood as the normal process of development. So anyway, we won that court case. Then what happened is, because Sue and I had been on television, we're contacted by lots of parents. Obviously, they're the skeptics who are worried about what's happening to the kids. There's a lot of other parents who are encouraging, some just in the background, they don't want to interfere, some encouraging, some very frightened, and they would contact us and say, we're really worried. We're not against John transitioning, but we're just concerned that this is not really looking at his underlying problems, and that he'll transition, but then nothing will be dealt with. And then how does that leave him subsequently? The demographic had changed now. So this is a completely different cohort, as I said before, 85% female to male. So completely different group, and present in a very different way as well. Sue and I wrote our first book, little plug for the book. That's for psychotherapists and parents, and we wrote that on the basis of our experience of seeing the parents, seeing the kids. It's not a political book. There's a bit about the political environment, but it's a clinical book because we're clinicians, not political activists. So shall I say just a little bit about the clinical presentation that we've come across in our private practice? Okay, so we don't see some of the older cohorts used to be seen at the clinic that's alongside the Tavistock called the Portman Clinic. It used to be called the Clinic for Sexual Dysfunction. And these were people with addictive perversions and the trans patients from the previous generation. I worked at the Portman for a few years, and the kids that get referred to us are very different from those patients that I saw in the Portman, where there's an identification, often male to females, an identification with the female body and various things that come with that behavior. And I'm not going to talk about that group, although I have seen a few. The kids that come to us, this is a general picture. It's not covering everything. And I had a bit of an argument. There's a guy called Michael Bailey who's written about autogynephilia and the sort of patients who get highly excited at the thought of get into women's spaces. And I think that's another subgroup. The kids that we see, they're terrified of sexual development. The puberty blockers are like putting a lid on their development. They're also very worried about their minds. They have very little bandwidth for what we would think of as symbolic thinking. They're extremely concrete. So, excuse me, I know you're translating English, French to English, but also I'm a Kleinian, and I don't know my French psychoanalysis as well as I would like to. But so if you picture a very fragile ego with an extremely harsh superego that deals with ideals, it has to be like this and that. It's black and white or paranoid schizoid. So that when you meet with the kid, they'll come, they've developed this certainty. It's like they get into a uniform called "I am in the wrong body and I need to transition." They have an idea of what life will be like when they've often developed like an as-if fantasy. When I'm a boy, as a girl, when I'm a boy, then everything's going to be all right. I'll be comfortable is a word they use a lot, because there's very little tolerance of the sort of what we would think of as the ordinary capacity to tolerate psychic pain, to be able to think about things from different points of view. So when they come to see us, I think often they've done a deal with the parents. The parents say, "We're worried about you and we want you to go and see Sue or Marcus." So they already think we're working to their mum and dad's script. And so we're the enemy when we arrive. We position ourselves to say, look, we're actually interested not in this narrow preoccupation with this thing called gender. We're interested in you as a person across the whole gamut. What are you like? What are you struggling with? What are your friends like? How do you socialize? What are your ideas? In a sense, we sort of stay away from the fixed belief that, I'm born in the wrong body, because you end up with a sort of unhelpful conflict. In the first instance, we're trying to get inside the mind of the child and understand the way they see the world, with a view that we're trying to open up their capacity to think and support them in developing curiosity about themselves. There's no curiosity about what it's like to be a woman if you're a boy. There's an embargo on curiosity when it comes to themselves, and it comes to examining what their beliefs are. That's felt to be very unhelpful. Again, you'll follow it. It's as if they've got their certainty. They know what the cure is. There's the door. They're trapped in this body. There's the door. They're going to go through that door into another world in which they can manage things better. And you're trying to shut the door, which makes them feel worse. So we try to avoid that and try to get alongside them and think about who they are. There's a lot of self-hatred. They despise themselves. Sometimes it's directed towards the body. Sometimes they're in identification with their femininity. The breasts are seen as, to do with mum, and I'm too close to mum, and I've got to get away from mum, and I need to establish a body of my own. So I'm going to get rid of, the anything feminine, and I don't want children. The boys are worried about toxic masculinity. My dad let my mum down. He was very selfish. I want to remove myself from anything masculine and emasculate myself and be extremely feminized. Often the drugs help this. You see young girls who've had a traumatic background and they feel very vulnerable. Testosterone gives them a sort of metal case around a fragile ego. Testosterone has a very upsetting effect. You can see the girls' Adam's apple developing, the jaw squares, their voice deepens. Effectively, what they often look like there's, I don't know if you know Peter Pan, this boy who doesn't grow up. They're a bit like that. So it's as if they're trying to look for the testosterone provides a sense of strength. And often there's a euphoria at the beginning of starting to take testosterone, as if they've defeated their vulnerabilities. With the boys, the estrogen, there's something hard about them internally, and the estrogen softens them, and they feel more, and they feel more feminized and away from this toxic masculinity, as I've described. So gradually you begin to open things up. A couple of the ideas that I've talked about, this is my second book. Sorry about this. I'm going to buy a yacht. My wife and I are going to be in the south of France. No, that's not happening. Anyway, and this is more for psychoanalytic psychotherapists. This is more an interested psychiatrist could read it and understand it. Anyway, and I think of a mentor of mine, two mentors of mine. One is John Steiner. Sorry for these theoretical ideas, but John Steiner developed this idea of a psychic retreat. Like development is a struggle and a challenge. You can move into a retreat in which there's a rigid series of defenses. The cost of it is development. And my view is that a lot of these kids end up sort of stuck in a sort of, they're not really children, they're not really adults. They're stuck in a sort of in-between world. And to some extent, that's what they're looking for. The other thing, by my other seminar leader, who's unfortunately just died, Ron Britton, he talks about, I'm sure you think about it in very similar ways, this sort of idea of a triangular space in the mind in which, you've got a sort of parental couple that can support the child looking at different things in different ways and supporting symbolic thinking. That's what we find is missing in these kids. One of the things, and that's what you're trying to help them develop in the psychotherapeutic work. They're very concrete early on. So you've really got to use your imagination. How are you going to talk to them in a way that you're translating a symbolic thinking into concrete thinking and backwards again? One of the things that's often said by the clinics is, the child was absolutely certain they wanted to transition, as if that's a sign of health, rather than if you're going to interfere with your body's natural functioning, you would expect to have doubts and be anxious. But there's a collusion, I believe, in the affirmation model between the clinicians who say, yes, we can remove your pain, we'll put you on the medical pathway, and the patient who says, yeah, that's what I need. So they both agree with one another, and it's as if all the pain and anxiety is in the parents, in the skeptics like Sue and I. They're quite certain. the thing is that there is a euphoria when in some kids, the problem comes when the euphoria drops off. So, I mean, I'm covering a lot of ground, but one of the things you come against is obviously the people who go on to have surgery, like Kira Bell. You see the surgeon, and the surgeon may say, yeah, of course, we can create you as a woman or you as a man. But of course, the surgeon can't. These are just facsimiles. They're man's attempt to imitate God. I'm not religious, by the way. And then, of course, with some people who've not been prepared, there's been no preparation, they're very disappointed. So I'll tell you one detransitioner I saw who, you get adhesions in the creation of a vagina the penis is removed and turned up into the body, a cavity is created. But the problem is there's no moisture in a surgically created vagina. So the vagina is always adhering. And you get all sorts of urinary tract infections and all sorts of problems, none of which is covered in terms of the risks and the terms of the consequences of these surgical interventions. Now, some people go on to make live a satisfactory life. But we believe with this new cohort, there's a whole load of people who've been pulled in by this social contagion and then going on to have operations. And we don't know what their lives are likely to be like. We do know that a proportion regret, and it's much more than 1%. The suicide rate is quite high post-operatively, and all sorts of problems when they reach middle age. But the problem is the clinicians involved are selling this as a short-term pain relief solution, which has got long-term hidden costs that they don't really talk about and the children don't understand. So there are all sorts of stings in the tail. But so I'm just here to say, that this is very, very difficult work. That's the other thing. Sorry, I was going to say one more thing. Going back to the political environment, after the court case, the Tory government, our last government, which weren't very good, I'm not sure this lot are any better. Anyway, they did one good thing. They brought in Hilary Cass, who was a very senior paediatrician. She got a crack research team. They looked at all the research in the world about this issue. And she came to the conclusion that there is very weak research of very poor quality, and that really what we've been doing is flying blind. A live medical experiment with these kids, and we have no idea what the outcomes are going to be. Now, one last thing, and I'll stop and we can move on. But Hilary Cass did say that she was going to do a puberty blocker trial because she was persuaded. I told her this was a mistake for various different reasons, that you could diagnose something called true trans. Now, I don't know what your experience is, but having worked in psychiatry for 45 years, I can tell you adult mental health diagnosis is notoriously unreliable. There's no bacteria you can see under a microscope, as you all know. And if Broadmoor is our high secure unit, you go into Broadmoor, you've got notes of 20 years, you'll see 30 different diagnoses, schizophrenic, manic depressive, by different clinicians at different times. And I don't mind diagnosis. I'm a bit unlike some of my analytic friends. I like a diagnosis as a ballpark figure. It doesn't tell you anything about the individual, but as a ballpark thing. Psychosis, neurosis, perversion, personality disorder. But the prognostic ability to predict the future, from early diagnosis is notoriously unreliable. And if it's unreliable in the adult population, it is even less reliable in children. I used to run the adolescent and adult service, and the adolescent department wouldn't diagnose anyone. You might get an idea, this person's developing a personality, this is psychotic, but you don't pin the diagnosis because you never know how that child's going to play out. So I said to Hilary Cass, she doesn't listen. You're chasing a unicorn. This is a psychiatric unicorn. There is no way of knowing which kids who say they're trans when they're 12, 13, 14 are going to be the small percentage that will go on to make a successful transition. There will be people who feel they've got to defend their position. Once you've had puberty blockers, once you've been on cross-sex hormones, the course of your development has changed. The question is, when you get to middle age and you can't have your own children, you may have matured and developed. How do you feel about that? How do you feel about that opportunity is no longer available to you? And I think these are judgments of Solomon. I don't think they can be made. And I'm highly suspicious. I don't mind research in the Institute of Psychiatry, but I don't believe everything I'm told by the researchers. I'm highly skeptical. And I certainly don't believe this. One last thing, just to say, I've just with Sue written a letter to our Secretary of State, Wes Streeting, to give my serious reservations about this puberty blocker style. I think it's program is unnecessary. I think that we need to start with psychological work. And many of the kids that we take on and see, they do open up their minds. Some may go on to transition. That's not my concern. I'm not the gatekeeper. But what I want is to encourage their capacity to think about themselves, reflect on themselves, and get to know themselves. And when they start, that is very minimally available. It's all shut down. But they do tend to change with some support and some experienced psychoanalytic understanding of what is being projected and how you try and get them to think about what's being projected. So I'm very angry about this puberty blocker trial. The other thing I'm told by the, people who know better than me, that they've got a crack team. Hilary Cass told me this, crack team. Well, that was blown out of the water when the crack team announced that they'd be put on puberty blockers and it would be tested after 2 years. After 2 years, they are still in a state of manic triumph, having overcome their developmental anxieties. So I've said to her publicly, this is nonsense, and shows me that you don't really understand what you're dealing with. As I said to her, lectured her many times, this is an identity development process that unfolds over time. And you're certainly not going to learn very much in 2 years. Anyway, sorry to finish on that angry note, but I'll stop there and then we can see where we go from here.
Thank you very much. Peut-être, Beryl, tu veux faire peut-être pas tout, hein, mais vraiment voir quelques points à retenir de ce qu'il vient de dire.
Donc dans les points importants, Marcus évoquait donc que sa femme Sue avait décidé en tout cas d'aller challenger le gouvernement étant donné qu'il n'y avait plus rien qui faisait autorité voilà, médicale du côté voilà, de la Tavistock. Et à ce moment-là, effectivement, devant la cour, donc le trust, donc l'hôpital, a dû présenter leur travail. Et en fait, le juge les a confrontés en leur disant, en fait, votre protocole de traitement des jeunes est basé en fait sur une simple et seule étude de 70 patients, donc qui est l'étude préliminaire des Hollandais publiée donc en 2011. Et où sont vos chiffres en fait? Et donc c'est à ce moment-là qu'ils ont été obligés de publier leurs propres chiffres où ils ont montré en fait à la Tavistock qu'ils ne reproduisaient pas les résultats des Néerlandais. Et Marcus nous indique effectivement que le point clé, en tout cas, voilà, de discorde est que si l'on suit les travaux de Kenneth Zucker au Canada, qui a suivi depuis donc les années 70-80 des enfants qui présentaient des troubles de l'identité de genre, quand on les supporte, qu'on est dans une approche thérapeutique, mais qu'on n'intervient pas médicalement, 85% en fait de ces enfants ne
Mm.
présentent plus de symptômes en fait de troubles de l'identité de genre par la suite et donc ne vont pas vers une transition. Et puis il y a 15% qui font le choix à l'âge adulte d'une transition, mais que si par contre en fait on s'engage dans un parcours effectivement donc de transition médicale et d'abord sociale, en fait, on inverse complètement le ratio des chiffres en fait et on a 80%, 85% de persistants. Et donc l'hypothèse avec laquelle les Hollandais réfléchissaient, qui était de dire en fait que les bloqueurs de puberté étaient une pause pour permettre
Mm.
de réfléchir, en fait, ne s'avère pas être une pause. C'est une première étape, en fait, dans le parcours de transition. Euh, donc, dans les choses importantes à retenir, en tout cas, et voilà, ce que Marcus nous indiquait, c'est que beaucoup de parents qui les ont contactés leur disaient, après qu'ils aient, sa femme et lui, exposé voilà, ce qui s'était passé à la cour et leur point de vue clinique, en tout cas à la télé, les parents disaient, mais nous, on n'est pas fondamentalement contre la question de la transition, mais en fait, on se demande si c'est ce qui répondra à tous les problèmes que présentent nos enfants. Et Marcus évoque, et je terminerai là-dessus, la question réelle d'un changement de population, en fait,
Mm.
par rapport aux personnes qui présentaient des difficultés d'identité de genre il y a une vingtaine, trentaine d'années. C'est qu'aujourd'hui, en fait, la cohorte de jeunes qui présentent ces difficultés sont en fait des jeunes terrifiés par leur développement. Vous disiez, Marcus, avec un ego fragile, quasi avec une construction qui pourrait être quasi un peu paranoïde, qu'en fait, voilà, ils se fixent, ils se rigidifient dans une certitude par rapport à eux-mêmes, et que ce sont des jeunes qui présentent une très faible capacité, en tout cas, de tolérer la souffrance psychique. Voilà, ça m'a fait faire lien un peu avec les théories de Mélanie Klein. Et donc, ils sont très peu tolérants aussi au point de vue de l'autre. Et
Mm.
donc, d'un point de vue thérapeutique, en fait, c'est justement pas en se focalisant sur la question du symptôme du genre qu'on doit travailler, mais c'est surtout, en fait, en les interrogeant sur voilà, leur vie de tous les jours, sur les aider à développer une curiosité par rapport à eux-mêmes.
Mm.
Et donc, au niveau effectivement de la prise en charge, ce qui se passe du côté des gens, enfin des médecins qui sont, on va dire, affirmateurs du genre ou du modèle affirmatif, Marcus décrit une forme de collusion en fait entre le médecin qui promet d'enlever la souffrance par rapport à ce développement pubertaire en fait insoutenable et le patient qui est dans cette attente en fait d'avoir une souffrance voilà, retirée. Et puis, on laisse en fait la souffrance aux sceptiques et à
Mm.
l'entourage. Et donc, il y a souvent une première phase d'euphorie parce qu'effectivement, il y a un apaisement de la souffrance. Et puis, les difficultés arrivent lorsqu'il y a la question du drop-down par après, où on se rend compte souvent, pour certains, après la chirurgie, en fait, que la question de la souffrance n'a pas été retirée comme on l'avait pu l'imaginer ou la fantasmer. Et qu'au niveau sociétal, effectivement, donc, ce sont souvent des filles qui sont tracassées par la question voilà, de la féminité et donc qui vivent une période d'euphorie avec la testostérone, en fait, et une augmentation un petit peu voilà, de la question de la confiance en elle-même. Et puis les garçons qui, eux, sont inquiets par la question de la masculinité toxique et qui, à l'inverse, se voient s'adoucir avec bloqueurs de puberté et puis des oestrogènes. Et effectivement, quelqu'un dans le chat parle du
Oui.
syndrome de Peter Pan. Et effectivement, c'était vraiment très intéressant. Ben oui, c'est un petit peu faisait lien avec cette question. Donc, ces enfants qui sont en fait coincés comme un développement un peu in between entre le monde enfant et le monde adulte, avec quelque part une demande qui est adressée, en fait, qu'on les aide à rester dans ce monde un peu in between, tout en restant dans
Mm.
l'imaginaire qu'on va leur enlever cette souffrance. Et la réalité, comme dit Marcus, c'est qu'en fait, dans l'immédiat, très certainement, on a une amélioration des symptômes. Et donc, le modèle affirmatif du genre, en fait, amène une solution temporaire dans le court terme, en fait, qui est soulageante, mais que le problème, c'est qu'on ne mesure pas le coût sur le long terme que vont devenir ces enfants qui ont été stérilisés, qui, lorsqu'ils sont en milieu de vie, et qu'ils ont effectivement eu toute une série d'interactions et autres qui les amènent au contact de leur père à se poser la question de la maternité ou de la paternité, alors que eux ne peuvent plus physiologiquement, en tout cas, voilà, en rendre compte, en fait, voilà, qu'en est-il? Et ça, au jour d'aujourd'hui, en fait, personne, voilà, personne ne le sait. En gros,
Ok.
pour résumer, voilà.
Ouais, merci beaucoup. On va entamer peut-être le débat avec Patrick Miller qui va
Yes.
apporter.
Marcus, first of all, I would like to tell you that I admire you very much
Mm,
for your incredible courage,
mm,
you and your wife, in confronting very early on people who wanted to not only prevent you from speaking up, but prevent everybody from thinking. And I
mm,
think that this um, is a very important aspect of what we are confronted with. And you said something that I found very interesting, is that this way, I would say this totalitarian way of preventing people to think freely, you said there must be something in connection with the difficulty to think and to represent, I would add, in the minds of trans people. So that's one thing that I find very important. And you also showed very well that actually what is being attacked and prevented is sexuality. And the notion of psychosexuality, which is a singularity of psychoanalytic thinking. And what you told us, which has been known for a long time, is that children, pre-adolescents who present what is now called gender dysphoria, but it's just a distress around their gender identifications. If they are allowed to go through puberty with the impact of the natural hormonal influx that challenges their minds, most of them change, obviously. But as we all know, puberty and adolescence is a painful moment.
Mm.
And there's another thing you insisted on, which I find very important, is the avoidance of psychic pain.
Yeah.
So in this sort of hatred of sexuality,
Mm.
we can also see an incredible misogyny
mm,
in these young girls or adolescents who cannot stand
mm,
their feminine bodies and want to do away with their feminine bodies. There's another aspect. It's the incredible homophobia that is lodged in all of this phenomenon, that a lot of these girls are so afraid of their attraction to other girls that they would rather think that they are a man rather than experience their lesbianism. And very often the family also is afraid that the child is homosexual and in some cases prefers the idea that the child is in the wrong body and everything will be fixed once he's become of the other sex. There's something I would like to share with you, and it's a very difficult question, but I think that we cannot avoid to look into the bigger picture, which is what we could call the contemporary discontents in our civilization, and wonder, what does it mean that in our culture nowadays there is such a denial of reality and a denial of the violence of reality, and how this denial of the violence of reality leads to avoidance of psychic pain, as you said, concrete thinking, and treating biologically what is a psychic conflict that could be understood and, you know, develop differently. So my question is, how come that this crazy ideology does not encounter much resistance in our culture within mental health providers, medical doctors, academies of all sorts, institutions, etc.? And what kind of collective unconscious pact is there that has to do with harming children, depriving them of their history, depriving them of their sexuality, and, in my view, committing a kind of soul murder? So what does it say about our contemporary civilization?
C'est passionnant, Patrick, ce que tu dis, hein. Passionnant. Même en anglais, j'ai tout compris. C'est passionnant. Marcus, do you want to answer?
Yeah, no, well, so many interesting points. I mean, it's one of the things that I've been writing about is this sort of idea, another contemporary idea, is there's a sort of conflict, isn't there, between a sort of liberal idea, no one should be confined to biological reality. Reality is a dirty word, as you say, Patrick. But then in some ways, the identity is claimed as a rigid entity, as if I know I'm this, rather than we are all a construction. I gave this silly example, you know, as a 63-year-old man, I can no longer cycle with my son and his mates because they go too fast and too far. You know, I'm having to get used to the fact that my identity as a very athletic man is now, I'm no longer as athletic as I was. And so identity and how we view ourselves is although we've got a sort of structure, it's not a rigid structure. It's always moving, importantly through puberty, as you're saying, Patrick, to include sexuality. But it's as if now it's seen as this this sort of rigid uniform which could exclude things that are going to bring you pain. Like, as you say, and I see this a lot, you know, that girls who have a problem with their mother, they may be anxiously attached. They feel betrayed because, you know, their mother had twins 2 years after them. So they're anxiously attached. Now they've been traumatized by twins. And it's as if they say, I've been betrayed by this woman and her sexuality, and I want nothing to do with having children, being a woman. I'm just getting rid of anything that could hold a baby, feed a baby. And it's the mothers often, again, a generalization, that are hurt so badly by their daughter's attack on their breasts and their capacity to have children. You know, the mothers are internally wounded. But I was just going to say, another thing that you mentioned is I had a bit of an argument over a stupid thing. I should never do it, over Twitter, with someone who'd replied to my Sue and my letter about the puberty blocker. And he was saying, well, a lot of these kids are very distressed. But psychic pain for me is such a relational thing. And I gave the example, you know, when my grandchild falls off his bike, the first thing he does is look at his mum. If his mum goes, he bursts into tears. You see, if he looks at his dad and his dad goes, all right, mate, you're okay, you're okay. See, so, you know, this idea that something called psychological distress is an isolated thing, detached from the container, who could help you say, come on, you're all right, that's not too bad. Do you see what I mean? That the experience of pain is, especially with children, is experienced in relation to someone else. And it looks to me as if, as adults, we've lost the capacity to contain our children's developmental anxieties. And as in the mental health profession, it's as if we say, you know, if you're in distress, we can concretely remove the distress, rather than, as you're saying, Patrick, we can support you through this process and through all the turbulence of the process. And it may help you develop your own capacities, rather than what we're doing is acting as if the child can't develop their own capacities, has to be given a concrete solution. And then they're not finding their own resources. So anyway, I loved what you said. I think you're spot on.
Yeah, but I also think, I mean, we could talk about this for hours because it's so complex. But I also think that there is an important factor why all of this ideology landed on a fertile ground that had been prepared, I think, by what we call the digital culture. Screens, smartphones, etc. And those concerned are children who were born with a smartphone in their hand.
Absolutely right.
And whose mothers sometimes were very happy to leave them with a smartphone. And, you know, I really wonder how you can develop a transitional object when you are confronted with a screen rather than your mother's face, for instance. There's also another aspect, because Céline used the French word sidération in the beginning, and there is a lot of sidération in what we talk about. And I think that there is a kind of fascination that certainly draws on many unconscious fantasies. Somehow the trans person has become a kind of heroic figure.
Yeah.
Someone who can cross all boundaries,
Yeah.
have no limits,
Yeah.
be self-engendered and not
Yeah.
the son or the girl from a couple who had sex,
Yeah.
and who can overcome what are the structuring elements of human mind, which
Yeah.
are the terror of castration
Yeah.
and the horror of mutilation.
Yeah.
And I think this exerts a great fascination and a freezing of the mind.
Yeah. The point you make about the kids that we see are very much online, exactly as you say. They are most comfortable online. They sometimes live a quite disembodied life. You can create an avatar of yourself. You don't have to, when you play games online, you don't have to be yourself. You can be a fictional character. And they're not attached to their bodies at all. It is as if the mother's or father has left them with a mobile phone, not help them integrate mind and body. They're dislocated.
Absolutely.
Yeah. Yeah.
Et peut-être Paul Denis, he has a question. Paul Denis?
Oui, je crois qu'il faut remercier grandement Marcus Evans et Susan Evans qui ont été les premiers à mesurer l'ampleur du scandale médical que représentent les traitements hormonaux et chirurgicaux des enfants se disant d'un autre sexe que le leur. C'est un scandale médical invraisemblable. Ces traitements médicaux ont été entrepris sans aucune étude préalable. Quand on étudie un médicament, on fait d'abord des études sur l'animal. On aurait certainement pu étudier l'effet des bloqueurs de puberté sur les primates et puis ne pas s'aventurer à des expérimentations directement faites sur les enfants. C'est ce qui a été le cas et ce que l'on continue à faire. Et Marcus Evans l'a dénoncé récemment en écrivant au ministre de la Santé publique de Grande-Bretagne d'arrêter, de continuer ces études qui sont bizarres puisqu'elles recherchent des éléments positifs à un traitement. Ils recherchent des arguments scientifiques pour justifier un traitement que scientifiquement on sait, dont on sait qu'il est nuisible scientifiquement. Les bloqueurs de puberté diminuent le développement du cerveau. Les bloqueurs de puberté freinent le développement physique. Les enfants qui en prennent sont d'une stature moindre. Céline Masson a rencontré récemment un jeune homme d'une vingtaine d'années qui prend des bloqueurs de puberté depuis 10 ans en attendant de savoir s'il doit être garçon ou fille. Et il est en fait resté un petit garçon, un peu plus grand que les autres. Mais il n'y a que des inconvénients à donner des bloqueurs de puberté et que des inconvénients à donner des hormones croisées, comme on dit. Alors, pourquoi est-ce que ça s'est développé comme ça? Certainement, la culture digitale dont parlait Patrick Miller à l'instant y est pour quelque chose. En tout cas, dans l'inflation du nombre des enfants qui se disent trans. Mais il y a autre chose, c'est qu'on se trouve actuellement devant une psychiatrie sans âme, une psychiatrie sans parole, une psychiatrie sans tête, une psychiatrie sans psychopathologie, où on s'en tient aux symptômes. Quand un
Peut-être,
enfant,
attendez, on va peut-être juste lui traduire, Beryl, la dernière, cette psychiatrie sans tête, peut-être traduire ça.
The thing that is, uh, I mean, difficult for the moment is that the psychiatry is without any psychopathology behind right now. It's just a psychiatry that just focuses on symptom and with a denial of all the process behind.
Yeah.
Sans parole, ouais,
Yeah.
sans parole,
euh,
sans tête.
psychiatry
Without head.
without psychopathology.
Hmm.
Euh, les psychiatres actuellement ont tendance à considérer un symptôme psychiatrique comme une maladie en soi. Ils ne cherchent pas ce qu'il y a derrière. On s'en tient au symptôme et on traite le symptôme. Et on le traite médicalement, de même qu'on donne des médicaments pour traiter l'angoisse ou l'anxiété, quelles que soient les causes de l'angoisse ou de l'anxiété en question. On se trouve en face de médecins qui, alors qu'un enfant voudrait changer de sexe, font comme si c'était possible. Or, ces médecins, comme nous tous, savent que changer de sexe est rigoureusement impossible. Ça n'a pas de sens. Même si on émascule un garçon, même si on lui fait pousser des seins, même si on lui donne des hormones, il restera simplement un homme, un garçon châtré à qui qu'on aura déguisé corporellement en fille. Mais il ne sera jamais une fille. Et cette imposture médicale est absolument invraisemblable. On ne comprend pas comment des gens sérieux, en France, en Angleterre, dans des pays civilisés convenables, ont pu se lancer dans cette affaire-là. Et je crois que Marcus Evans a eu le mérite, le premier, de dénoncer cela. C'est grâce à lui que le rapport Cass a été diligenté, et c'est grâce à lui qu'on commence à interdire la prescription de bloqueurs de puberté et d'hormones croisées dans différents pays.
Merci. Merci, Paul Denis. Ouais. Yes, comment on dit ça? Ouais, bah, tu lui, ouais, je sais pas comment on peut traduire. Bon, Beryl, peut-être juste dire, oui, que il remercie, en fait, Marcus Evans pour son.
He thanks you a lot,
Ouais,
Marcus.
c'est.
The fact that you've been, I mean, one of the first whistleblowers, and that
Mm,
your help, you know, there have been things moving in England,
mm.
of course, and then just he admires you also, as Patrick said.
But I also, you know, this point about psychiatry, you know, I like psychiatry. I'm a critical friend, like I am of diagnosis, but I agree. Psychiatry is heading in the wrong direction. It's getting further and further away from thinking about the person as a whole, and more thinking about the symptoms as divorced from the person, with increasing number of diagnostic categories. I was listening to a program, and this is partly what I'm trying to make people aware of about this puberty blocker trial, is they'll be obsessed with not what's going on with the personality, but what's going on with the symptoms. Of course, the child will feel euphoric that the symptoms are desisting, but how are they developing? At what cost in terms of their development? Because development involves conflict, as I think Patrick mentioned, conflict, and that's how we develop. It's like we're trying to get rid of conflict and pain and awkwardness, but at what cost? I was listening to a program last night. It was about DSM, and it was alarming the way that these new diagnoses are just developed. And DSM is getting bigger and bigger with more and more subsections very little sort of research into what these diagnoses are and how does it help anybody. I think psychiatry is going in a terrible direction. Anyway.
Thank you. Perhaps, yes, one question, Marcus. What is happening today for these teenagers? Where they've been referred when they are feeling that they are not in when they feel they are in the wrong body, where they are referred? Yes.
Okay, so here's another disagreement I had with Hilary Cass, was that I thought they should get rid of the speciality of gender medicine. I think the moment you send them down the speciality path, you're narrowing the way they're seen. These kids should be seen in ordinary generic child services. The sorts of things that we've seen in previous generations to do with the control of the mind and body in like anorexia or self-harm, these kids are tyrannically controlling. Patrick mentioned tyranny. They have a tyranny of control. They want a flat mind and body. And we've seen this before with anorexia and self-harm. And in my view, they should be seen in a generic not looking at the family dynamics, their developmental history, good psychiatry, not specialist narrow services that just focus on this invented thing called gender. It's, it's closing their mental and physical minds down into a narrow rabbit hole. Anyway, I'll tell you what's happening. Hilary Cass has set up 3 specialist gender services, and she tells me that they're going to be managed by very experienced, good staff. I'm afraid I don't believe a word of it, because staff who gravitate to these services are already often very ideologically driven. It's like a religion. So they won't get the sort of breadth of thinking that the kids need to open their minds out.
Et qui a une question parmi les panélistes, parce que on suit vos commentaires sur Nathalie Lutte notamment, qui est pédopsychiatre. Elle dit yes, yes, read the message of Nathalie. Yes, would you agree that when it comes? Okay.
I mean, look, people think I'm a fanatic. I get called a right-wing Christian bigot. I've been banned from speaking at conferences. I've never been I'm not particularly political. I'd rather go down to the rugby club and watch France play some beautiful rugby than I would become a political activist. But what shall I say? Within the services, the leaders are like in a religion. They fanatically believe they're doing the right thing. No matter what Hilary Cass says, they dismiss Hilary Cass as a bigot, when all she's done is look at the science and present the facts. And so anybody who challenges the sort of fanatical belief in this affirmation system is then accused of being transphobic, and that you're going to endanger trans kids. So, my wife and I are told we're going to be killing trans kids just by being free to talk about our doubts and questions. So there is a tyranny in the staff group often. It's like this. It's like Patrick mentions this super ego, isn't it?
Oui.
In my language, that hates the freedom of thought. Reminds me of Bion's attacks on linking. Any thought that brings us into contact with others we have feelings towards, we're dependent upon, is immediately attacked and shut down. And that was very much what I saw in the Tavistock. I'll give you, I've written another paper, which I'm aiming to get published soon. But in the Tavistock, we had a tradition of presenting a scientific meeting to the whole of the trust. It's a small trust, and we'd all have to present our work. And no one liked doing it because the other families, the Children family, there's a bit of rivalry. And so there'd be a fight between the departments. The JIDS clinic never presented once. In 20 years, they didn't present. And the reason being is they're so narcissistically identified with their service and so fearful about, the fact that all thinking's being projected and got rid of. They fear a sort of attack on their whole methodology, which is, as I say, religious certainty. I mean, it's not the culture of the Tavistock, or it wasn't the culture of the Tavistock. Yeah.
Que quelqu'un a une question?
Oui, je peux dire un mot.
Oui.
Vous insistez dans ce que j'ai pu lire de vous sur plusieurs symptômes qui accompagnent la demande de changement de sexe. En particulier, le dégoût des jeunes filles d'une douzaine d'années par rapport à la sexualité, par rapport à la féminité, par rapport au corps, la grossesse, la sexualité. Et d'autre part, sur une formule qui revient souvent, ce corps n'est pas le mien. Si bien qu'on peut se demander si, dans cette demande de changement de sexe, il n'y a pas surtout la demande de supprimer la sexualité plutôt que de changer.
Did you understand, Marcus?
No, my French is not as good as I would like it to be.
Comment on pourrait traduire?
Behind the demand of changing my body, is there more the question of can you avoid me from being confronted to sexuality? So
Yeah.
I mean,
Yeah. So
c'est plus qu'annuler, hein, c'est plus qu'éviter la sexualité, c'est de l'annuler. Hein, c'est ce que vous disiez, de la supprimer. Ouais. To suppress sexuality.
Yeah.
Ouais.
Yeah. Well, I think they're all like. So there's we got two groups. One was the early group at puberty. Now we get, because puberty blockers is stopped now by Hilary Cass. Now she's going to have a trial. So anyway, but the other group we get is leaving home to go to university. All of the challenges of separating sex, drugs, rock and roll in university. And then you get another peak, because I think these kids are terrified of their sexuality in the way that you're saying. And yeah, so the younger kids want to stop sexual development. The older ones are frightened that they have developed sexually mature bodies and they don't want to get involved in sexual relationships. So they put a lid on it. What I would say is that one of the things that we hear a lot is that Kira Bell say she's trapped in inside a sort of gang, right, Rosenfeld's gang in this belief system. She hopes that someone can find the bit of her that is worried about what she's doing. Okay. And that may appear at different times. At times, Sue's seeing someone going for a double mastectomy next week. She's absolutely certain. She sees Sue. She then phones up.
Right.
I've cancelled the appointment. Okay, because the doubt comes in. For some, they go through the transition and then they say, I don't think it was necessary. So the doubt is never allowed to emerge until they've gone through the physical changes. With others, that if you can get hold of the part of them that is worried about what they're doing, you may be able to help them out of their enclave. But, you know, so it varies as to what point. But interestingly, just one more thing is sometimes you see that the kids will go, I'm not interested. I'm coming because mum and dad sent me. But they keep coming. And you go, oh, right, okay, you tell me a bit about yourself. Do you see what I mean? And they keep coming and they start to get interested. The problem is it takes time and quite a bit of skill. And that's the problem. It's not easy work.
I think what you're saying has to do with allowing those kids to reconnect with themselves, with their bodies, and with a sense of their history, and with a sense that they have a history that is their own. Because I think that in this whole phenomenon, there is a kind of passion for erasing the origins at multiple levels, from the primal scene to more secondary levels.
And we see the histories, Patrick, in the family. Older child had lots of trouble. The parents were very preoccupied. Younger daughter, very pretty and popular. They're the middle child, lost. Don't feel the older son was mum's favourite. The younger daughter was dad's favourite. I was a tomboy in the middle. You hear of these dynamics time and time again. And they don't want to disclose their history. It takes a bit of time for them to say, yeah, I was the difficult one. I was the one who I couldn't find my place in the family. And once they start to tell you their history, then you know you've got a patient.
And don't you think there's also, in many of those kids, a transgenerational history of traumas of different kinds?
Yeah, absolutely.
But including sexual traumas.
The incidence of looked after children is very high. Looked after children, they are high up on the list. And or children with traumatic histories, that's another very high incidence.
I mean, it's the ready-made suit to be trans-identified and to have like a novel identity, just to erase, as Patrick said, all the origins, and to give you the illusion that you can escape from something without the need, without having to bear all the past and the transgenerational history of suffering. And so it's a very powerful kind of ready-made suit for them to be able to stick with.
One of the other things that I think I come across quite a bit is that they develop a sort of a picture of what the what the parents would have wanted as the ideal child.
Mhm.
And they don't feel they measure up. So, you know, one is very simple example. I mean, there's one girl, and there were three girls. She was the middle girl, and she had a fantasy that her dad always wanted a boy. Now, I'm sure the dad didn't want her to transition, but she's got that a sort of fixed belief, you know, that she would be the ideal loved child if only she'd been a boy. And she was a footballer. Her dad loved football. It was as concrete as that. So I think those internal fantasies about where you measure up against the imagined parental ideal, and often the kids feel they can't measure up. You know, they're awkward, they're a bit, you know, they're not the good looking one, they're not the sporty one, they're sort of like awkward child. And it's almost as if they rebel against it. They go, well, if I can't be, you know, the love child, I'll get rid of, as you're saying, Patrick, I'll get rid of the child you had. You, mum and dad are no longer gonna have John, you're gonna have Joanne, this child you've never met, you know. Yeah.
The dead name.
The dead name. Yeah. Yeah.
Je voulais vous interroger sur la question du contre-transfert
Yeah.
avec les enfants qui veulent changer de sexe. C'est terriblement angoissant pour les parents et je pense que c'est très angoissant pour le thérapeute ou pour le consultant. Et je me demande si, dans le choix d'une thérapeutique médicale immédiate, il n'y a pas pour le médecin une façon d'échapper à la tension anxieuse, angoissante de la relation avec ces enfants qui sont très fixés dans leur demande de changement de sexe.
Did you understand? Yes. About counter transference.
Yeah, no. And I saw a very interesting question where about parents, which I'll come on to. Well, I mean, look, it's tough because, you know, I've had the experience of, say, so one of the girls that I write about in the book, very traumatized background, really traumatic background, and felt she was very vulnerable as a girl in the adult world. And then she was like a cherub, she's a beautiful girl, but she started taking testosterone. And this was the one, you can see the changes going on in front of your eyes. Sorry, I've forgotten the question again. I've gone on to think about something else. What was the question again?
Paul, vous pouvez juste répéter la fin. J'ai zappé aussi la fin de la
Comment
It was about the counter transfer.
Yeah, counter transfers. Absolutely. How can I forget it? I'm dementing. I mean, so you're either provoked into taking them on about their trans beliefs. So they say, I've come here to talk about my gender, and we don't talk about my gender. And we want to get you into a bit of an argument. You're a transphobe, I know you are, you know, and you end up in an argument. That's unproductive. The other thing is worrying that you're getting on well, but the contentious issues are outside. And you, like the parents, want the therapeutic relationship to continue, but you're worried that there's some incubating idea which you're not dealing with. So that problem of you don't want to be provocative, but you don't want things to be too calm either. How do you negotiate that? And then, of course, because the kid can break off if they don't like what you're saying, or they can threaten to break off. And the other thing you have is things are going well, like with the girl I mentioned who's taking testosterone, and you feel you're really getting somewhere, and then she'll come in and say, yeah, but I've booked an appointment with the surgeon. I'm going to have a double mastectomy. And then you've got to deal with the provocation of how to try and understand what's gone on without, you know, being too controlling and becoming like a policeman and saying, you know, what are you doing? You're mad. And that makes a demand on you, because sometimes you don't know, you think, well, it's a negative therapeutic reaction, but I don't really understand how to take this up with her in a way that we could bring this problem into the therapeutic situation. So it's the countertransference is demanding. But I have to say, I try not to think I'm responsible for what happens to the child. I'll do my best to understand the child, but I'm not. The parents think you're going to talk sense into them like a policeman. And I go, I can't do that. I have to try and understand what's going on. Yeah. There was someone who asked a question, I just saw there, Céline, on the parents who see, so we see parents who've seen what we say and they come to us. When Sue worked at the JIDS, you see the parents who are cheerleading. Now, one of the things that I think often goes on, particularly with the younger kids, is there is a sort of folie à deux between sometimes the mother and the child, you know, in which the father is sometimes, this is a generalization, but is excluded. And you've got a sort of, they're a sort of, they've made the couple, they become the couple. Not always the mother. Sometimes it can be the father and the mother and the child against the mother. But it leads to terrible splits and divorces, and couples break up over it and they go to court over it. So the trans thing, your point, Patrick, we come from two parents, whether we like it or not. The whole issue drives a coach and horses between the parents sometimes. I'll just say one thing about the work that Sue does with parents. This is not all kids by any means, but some parents she presents, and you get very professors, very academic, you know, people who are used to with a high status. When it comes to their trans kids, they've lost their authority. They feel that the child is ruling the roost. And as you were saying, Beryl, there's a sort of dominance of the family. And what Sue will say, well, we don't know how to tell you how to parent, but you are entitled to get back in your position as the parents of the family. It's like old school family therapy, you know, get back into a position, reduce the child's omnipotence, and a proportion of them will phone up 3 weeks later and say, he's dropped the whole idea. And all that's happened is that mum and dad have got themselves back into a position of being mum and dad. That's I'd say, you know, that happens with 15-20% of the parents we see. Most of them, it's not that simple, but with some, it's a little bit of couple work and it goes a long way.
We have the same experience with the parents.
You have the same, say again?
Yes, we have the same experience with the parents.
Yeah. Almost like the child is crying out for mum and dad to take back control of the family, you know, and you think, oh, thank God for that.
And not only for gender issues, it's for like many symptoms in child psychiatry. So it's now
Absolutely.
the therapeutic process that what is bizarre right now, it's that it's validated by neuroscience that bringing back kind of authority with kind of parental training and coaching and blah blah blah. It's just like
Mm.
working to treat the symptoms. And so
Yeah.
because it's kind of validated by neuroscience, then people would agree with this. But
Yeah.
if you arrive with your psychoanalyst label, then you know it doesn't work that well.
Ok, on va peut-être s'arrêter là et we will like to thank you so much, Marcus and Patrick, for your excellent presentation, and I'm sure we will have again the opportunity to speak and to invite you perhaps one day in Paris. Comment on dit ça en présence,
In person.
in person, in
Lovely.
person,
That would be nice.
Much
Body,
nicer.
body and
Oh,
mind.
yes, body and mind, yes. Merci beaucoup à tous d'avoir participé à ce débat, cette conférence débat, et on se retrouve, j'espère, bientôt. Voilà. Merci beaucoup, Beryl, et merci beaucoup, Paul, Denis, pour vos interventions, Caroline. Voilà. À bientôt. Thank you
Thanks
very
very much
much.
for having
Bye
me.
bye.
Thank you.
Bye bye.
Bye. Bye.
Bye
Bye.
bye.